people won't cry because I'm not recording. I do. All right. As a review then, the hydrostatic pressures purpose is to push the fluid out. If I'm looking at a vascular, an intracell, or a cell in the interstitial space, there's going to be a hydrostatic pressure inside the capillary pushing fluid into the interstitial space, and there's going to be a hydrostatic pressure in the interstitial space pushing fluid back in. Okay? In the case of, as we're going from the arterial side of the capillary to the venous side, there's going to be a movement of fluid into the interstitial space. Towards the venous side, it starts moving in the opposite direction. When we have a case of pulmonary edema, what is the capillary hydrostatic pressure? I want to make it's elevated. Is there a measurement we can use to get a... Yeah, PCWP. So as we see that value rise, we know that the hydrostatic pressure here is rising, and it's pushing fluid out and into the alveolus. Okay? Hydrostatic pressures push fluid out. Conversely, osmotic pressures pull fluid in. So here's my capillary again. Here's my cell. These large particles that are inside the capillary, as they float through, pull fluid with them. In the case of the interstitial osmotic pressure, there really isn't that much interstitial objects located inside that space, so there's not a lot of net fluid movement inward because of that. If for some reason, however, the capillary permeability, which if you remember is the fifth factor, should become altered and allow for those big things to move into that space, and you could and potentially end up having interstitial edema from the fluid being pulled in by those products. Okay, but there is one in the capillary, and potentially there is one in the interstitial space. And this, again, this is that little drawing as we go from the arterial side to the venous side of a capillary. There's movements from osmotic and hydrostatic pressures, and notice that the hydrostatic pressure drops across the capillary. It would have to in order for blood flow to occur, but in the process you end up having a net change of 8 going in, 7 coming back out, so you basically have a small amount of fluid that is left in the interstitial space, and that is eventually cleared by the lymphatic system, and everything's hunky-dory. Okay? So let's see how that applies to our nephron, our functional unit of the kidney, because this entire organ system, or this entire functioning, that's what I'm going to look for here. This thing functions on hydrostatic and oncotic pressures. Put it simply, how's that? Okay. This shift of fluids in and out of the vascular space through the glomerulus, Bowman's capsule, and into the proximal tubule, and eventually then into the collecting tubule and out through the ureters, all works on based upon those simple concepts that we just talked about. Okay, as well as the diuretics that are, some of the diuretics we're going to talk about. The key components are the efferent arteriole, which is the arteriole which is bringing blood to Bowman's capsule, of which consists a tuft of capillaries called a glomerulus. We'll talk more about them in a second. Exiting the glomerulus, there's an efferent arteriole. And then what follows then is these peritubular capillaries, which surround the proximal convoluted tubule, which is this portion here, convoluted, proximal to the glomerulus. And as that floats by, those peritubular capillaries continue to exchange fluid back and forth with the proximal tubule. There then is a descending loop, which depending upon the location of the nephron can be either very short or very long. There's an ascending loop. Totally different things happen. And then there is, it's not on there. Why isn't it on there? The distal tubule. Once this comes back up around this portion here is called distal tubule, or distal convoluted tubule, which eventually dumps into the collecting tubule. Does this vaguely ring a bell? Okay, good. Or not good, depending upon who shook or nodded their head. So let's talk about Bowman's capsule. These are typically located in the cortical portion, not typically, they are located in the cortical portion of the kidney. The end of Bowman's capsule is the beginning of the proximal convoluted tubule. Blood enters into this structure via the afferent arteriole and branches into the series of capillaries called the glomerulus. It is the hydrostatic pressure, hydrostatic does what? Pushes out. That pushes the, because, this is my glomerulus, because the pressure in the afferent arteriole is higher than the pressure in Bowman's capsule, fluid is going to move from the capsule, from the glomerulus into the capsule. Okay? So there's a net movement of fluid out of the vascular system into this area. Okay? And that hydrostatic pressure is caused by the contraction and dilation of both the afferent and the efferent arteriole. So here's my afferent bringing it in. Here's my efferent bringing it out. If I increase the afferent arterial pressure, more fluid is going to move out of the vascular space into the Bowman's capsule. Does that make sense? Increased pressure, more fluid's going to move out. There's a bigger pressure difference that exists. A reduction in efferent will do the same thing. So the kidney, these localized arterioles can regulate how much fluid is moved in and out of the Bowman's capsule. So if the body, for instance, is dehydrated, it can reduce, by reducing the afferent arterial pressure, reduce how much fluid is dumped into the Bowman's capsule, proximal tubule, eventually urine. It's one of the ways it's regular. If by decreasing afferent, I then have less driving pressure pushing fluid across, less is eventually going to end up as urine. Okay? So there's ways that the body can control the amount of blood that goes through that glomerulus. Roughly only about 1/5 of the blood is filtered through the glomerulus. The others, 80% is just allowed to pass on from the afferent arteriole back into the efferent arteriole. Doesn't get affected. Okay? And that's what this is basically saying, is that as it passes from, if this is my afferent going into my glomerulus, coming back out to the efferent, they then actually go to the peritubular capillaries. So that winding thing that's going to surround the proximal descending loop, ascending loop, distal loop, distal convoluted, those are all those same capillaries that eventually started way back here. Okay. Once the fluid is dumped out of the glomerulus into the proximal tubule, it is then dumped into the proximal convoluted tubule. So from Bowman's capsule, dumps directly into this next structure. 3 factors are involved in the formation of urine. One is something called the glomerular filtration, and that is basically based upon renal perfusion. So remember, we're taking fluid out of the vascular space from the glomerulus, putting it through the series of tubules, and eventually secreting it out through the urine. Okay. How much, as I mentioned, as I constrict those afferent arterioles, drive the pressure up, I'm not going to allow as much, I think I may have said this wrong then, excuse me. As I drive the pressure up by constricting it, I reduce the glomerular filtration rate because I'm not pushing as much, I'm not allowing as much blood flow through that. I had it backwards earlier. So let me go back and reiterate myself because I said it wrong. If I have a situation where I have a reduction in, I'm dehydrated. Body sense that there's a reduction in the amount of circulating blood volume, preloads down. It's going to go ahead and vasodilate the afferents. By doing that, you're not allowing as much blood to be pushed through the glomerulus. No. It lowers the pressure. So it keeps fluid in the vascular space rather than letting it passing out through urine. Does that make sense? As it vasodilates, there's not a big pressure difference between what's in the vascular space and what's in the Bowman's capsule. So if there's not a big difference, not a lot of fluid is going to leak out of the vascular space. It's then going to pass back into the efferent arteriole and back into the system. So in other words, I'm retaining water because I'm dehydrated. If it constricts, it increases the glomerular filtration because it pushes it out of the vascular space. Correct. Correct. So bottom line is it's the control of these two vascular, these arterioles that allow for that change in glomerular filtration rate to happen. More filtrate, more potential urine output. Less filtrate, less potential urine output. Think about what we're doing. Think about what we're doing. As I push more fluid out of the vascular space into the Bowman's capsule, that potentially could never be come back in again. That could be fluid that is ultimately lost in the form of urine. Same thing would happen on the efferent side. Here's my afferent coming in. That's a glomerulus. And there's my efferent. If I increase constriction here, the pressure in here is going to be higher. The amount leaking out then is going to be greater. So fluid will be lost from the vasculature into Bowman's capsule and potentially increase the urine output. So these are basically doing opposite things, but you can see that they're both constriction. Make one of them dilation and you do the opposite effect. And we'll go back through this, don't worry. I can see Dana shaking her head already. Okay. So if I'm dehydrated, I can vasodilate the afferent. Yeah, just leave it at that. So all right, that's one thing that results in urine is this control through the glomerulus. Second thing that affects the formation of urine is how much is ultimately reabsorbed. Once that fluid is pulled out of the vascular space in the glomerulus, dumped into Bowman's capsule, it now goes through these proximal convoluted tubules, descending loop, ascending loop, and ultimately the distal convoluted tubule. Unless that fluid is reabsorbed, it's urine. So one of the functions of the kidney is to pull that fluid back in again, and what we're going to find is that our various diuretics work by preventing that reabsorption at one point along the line or another. And different diuretics do it in different ways. Different diuretics do it in different locations. Okay? And then finally, the other function that has to do with urine is the fact that we need to make sure that we're managing the electrolytes also. So in the case of, let's say, hyperkalemia, the body wants to do something to dump the extra potassium. Okay? It's going to control that, or perhaps even controlling this, for instance, the bicarbonate ion. That's what is done in those tubular secretion also. It allows for bicarb to be reabsorbed or allows for bicarb to be excreted. It allows for potassium to be reabsorbed or allows for potassium to be excreted. depending upon the blood levels. Is this new? Did we cover this in A&P? No, okay. Not that in depth, okay. All right. So let me go slowly through here again, because I think maybe I'm making matters worse. So fluid that comes into the glomerulus, we're going to call that the glomerular filtrate. Okay. It's dumped out of the vasculature into this collecting chamber, Bowman's capsule. Bowman capsule then has an outlet known as the proximal convoluted tubule. And surrounding that proximal tubule is this collection of capillaries that were an extension of the efferent arteriole. Now, if you think about it, if I take a good portion of fluid out of that vasculature, what is left in here is everything but proteins, albumin, hemoglobin, big particles, because the big particles can't be filtered out. Does that make sense? Other than that, they're pretty much the same kind of fluid. Whatever was in the bloodstream is filtered out, same constituents there. So sodium, potassium, glucose, not so much glucose, sodium, potassium, chloride, bicarb, hydrogen ions, whatever. Same concentration in this fluid, which could eventually become urine, as was in the arterial system coming into the glomerulus. However, what is in this proximal tubule has a very high osmolality. Because these things are really big and ugly, proteins have a very high osmotic pressure. Albumin has a very high osmotic pressure. Yes? No? What does a high osmotic pressure do? So what is it going to do as these capillaries are surrounding this proximal convoluted tubule? It's going to pull the fluid back in to the capillary, back into the vascular space, and not allow it to be excreted as urine. Okay, so what's exiting the glomerular, we're going to call the glomerular filtrate. And if you look, you don't really need to know most of these numbers, but it's roughly about 125 milliliters per minute, which is 180 liters per day, which is roughly, if you only have 15 liters, how many times is it recirculating that through the kidney in the period of part of a day? Like 12 times. It's a very efficient organ. Here's the key part I want you to remember. Ultimately, as it passes through all of the renal tubules, 99% of whatever was filtered out is going to be reabsorbed. So you only excrete about 1%, or basically about 1 milliliter per minute. The normal is 125. 1% of that is a little bit more, 1.25 milliliters per minute of urine. So quick and easy way to remember, in an hour's period of time, how much urine did you see produced? 60 milliliters. Maybe slightly higher than that, but roughly. Okay? So I know you guys monitor urine output on your mechanically ventilated patients all the time, right? Sure, whatever you say, Rick. It's a way to remember. A little over a milliliter an hour, which is what you should end up seeing. Okay, so let's talk about why it gets reabsorbed. Look at the proximal tube. Pardon me? I'm sorry, a milliliter per minute. A little over a millimeter per minute. Thank you. Milliliter per minute. Okay, so I went through my Bowman's capsule. I came out now with my proximal convoluted tubule, which is being surrounded by this vasculature that's very rich in osmotic agents. albumin, hemoglobin, proteins, all those things that are have very high osmolarity, which if you don't know what that word means, it means that it pulls stuff. Okay? Technical name for it. But those peritubular capillaries are very high in osmotic pressure, so they're going to pull fluid. If this is my proximal convoluted tubule and these are my vasculars, it's going to pull fluid out of here and back into here, which is what you want to do. You want to reabsorb the water. You want to reabsorb things back into the vascular space. And again, the proximal convoluted tubule starts at the end of Bowman's capsule and continues on to the beginning of the loop of Henle. So here's kind of where I'm talking about. This portion right over here. Fluid has been pulled out of the vascular space. Now as it continues through here, you can see there's a very high in amino acids and glucose, and basically what you end up having is you end up having water being pulled out, and instead of being this nice blue watery substances, now it's starting to turn yellow, like urine. Okay? So that's that whole process of what is basically fluid moving back in again. 65% of all glomerular filtrate ultimately is absorbed back in the form of water. There's also some reabsorption. These are very permeable that they can reabsorb some amino acids and glucose unless there's an elevated level in the vascular space. So if I have a high blood sugar, this is where they end up spilling the protein and spilling the urine, or spilling the glucose into the urine that's not reabsorbed back in again. And if you think about it, if these were out in the filtrate and are now being pulled back in, they're big osmotic guys, they're going to pull a lot of water with them. It's kind of the whole cycle that goes there.
Just to clarify.
Yeah.
The slide previously says 99% is reabsorbed, but are you talking only of water then? It says 99% is reabsorbed?
Overall of what is filtered out of the vascular space into Bowman's capsule, 99% of it is ultimately reabsorbed by the time it gets to the very end.
Okay.
Yes, thank you for clarifying that. In addition, the other thing the proximal convoluted tubule does, other than 65% reabsorption, of water, is that you end up having sodium reabsorbed in an active fashion. And again, ultimately, virtually all of your sodium is reabsorbed. But this is the starting point where there's an active reabsorption of it. And that active term is key. Okay? And again, this is continued as you go down further, but this is where the most of it occurs. And we're going to call this active reabsorption of sodium as the sodium chloride mechanism. There's 3 different ways that sodium is ultimately going to be reabsorbed. The first one of which is using an ATP pump, which means there's got to be energy applied to pull the sodium back in again. Sodium inside the tubule, this is what would ultimately become urine, pulled back in, exchanged for potassium. To maintain some neutrality, you also pull back chloride with it. So that's the active mechanism for pulling water back in, or pulling sodium back in. Let me write something here. Keep this in the back of your mind. As sodium goes, water goes. So if I wanted to create a diuretic, I would do something to block sodium reabsorption. Right? Someone who has a high blood sugar, they're going to end up having a lot of blood sugar remaining in the filtrate. So that's going to keep water in the tubules, which ultimately means they're going to have a higher urine output. And that polyuria is one of the keys that you got an increase in blood sugar. I feel like I'm speaking French. Hey, do you know where this came from? This picture? He does a really good job explaining all of this in the process. Egan. And I got a feeling I need to stop there. I'd